many of you already, oh, okay, we're recording. Many of you already know Dr. Levy. So he and I work together at Wayne State University in the School of Medicine in Detroit. Dr. Levy is the Chief Innovation Officer for Wayne Health, which will probably end up telling you some more about because Wayne State's system is quite convoluted. Wayne Health is not, it's not really, well, you can explain it, Phil, how it's involved with the School of Medicine, but it's not necessarily a clear relationship. But the thing I want to brag about with Dr. Levy is, you guys all know he does a lot of population health research, and he's got an NIH grant, a P50, which is, when I asked Jeff, what's a P50? I've never heard of it. He said it's basically like 3 R01s all at once. So extremely impressive. And I think you're the first in emergency medicine to ever get one.
I think that's correct too.
So that
At least that's what Jeff told me also.
Super cool. So without further ado, Dr. Levy's going to talk to us about life beyond emergency medicine.
Oh, thanks, Anne. And it's great to see a lot of familiar faces, and I appreciate the opportunity to get back into speaking with some EM folks. I've taken a little bit of hiatus from the other organization that begins with an A but shall remain nameless, but have maintained my work and affiliation, at least to some degree with SAEM. And, I think in a lot of ways, this organization has really emerged as the truest representation of who we are in academics and EM. At one point, I had to justify to ACEP why we were still paying for a research forum and why research still mattered to the run-of-the-mill ER doc, but that's never been the case with SAM. And so I think something like this, having vice chairs come together to talk about academic trajectories is emblematic of that type of thinking. And, I'm somebody that also started out, and again, I know a bunch of you guys pretty well over the years, but I'm somebody that started out as the rariest of emergency medicine people, right? Trauma surgeons get out of my resuscitation room and chest tubes here, and let's put the flag in the sand for emergency medicine. And then over time, as Anne just alluded to, I've really evolved my career to think much more broadly, not just about emergency medicine, but about the space that we as emergency physicians play in the broader healthcare continuum, especially in population health. And so my work has long been focused on high blood pressure and reducing cardiovascular disease, started out emphasizing and focused on acute cardiovascular disease, especially heart failure and acute coronary syndromes, but over time migrated towards not the 15% of people who get admitted to the hospital, but the 85% who don't, recognizing that as the teachable population health opportunity in emergency medicine. And over time, started really looking at ways to incorporate that usable and useful information we get on all patients' vital signs and other screening tests, but not just focus on the disposition of the patient from the ER, but what happens next, and set up a lot of infrastructure around research in the ER specific to that, doing linkage of care, having community health workers in the emergency department, but was always kind of looking beyond emergency medicine, at least from the mindset of how do we reach our populations most effectively so we don't have 35-year-olds coming into the ER who need dialysis because they haven't controlled their blood pressure in 10 years. And it's not that people wake up in the morning and say, I'm not going to take my medications, or, I really want to have the worst blood pressure control of my family. It just happens, and there are circumstances that evolve. You guys all know this. And how can we really rethink not just emergency medicine, not just my role in emergency medicine, but healthcare in general, so that we can really get at the primary thing that I think we all went into medicine for, which is not the excitement of a resuscitation, but really, reaching a human being and having them, get that therapeutic intervention for whatever it is they need. And sometimes it's not going to be something that gets resolved during our time together in the ER. It's going to be teaching them that, this is what they need to focus on for the rest of their lives. And so, that's a lot of what we're going to emphasize, because we were building up the infrastructure for all this stuff prior to COVID, and then COVID hit, and it really gave us an opportunity to accelerate and change course on this vision to the point now where I barely work emergency medicine. I work on average one shift a month, and I usually group those into blocks of 4. So, I'll do 3 blocks of 4, and that's all I do a year. And it's really at this point to maintain my credentials. And it's not so much that I don't feel that emergency medicine, has value. It's not that in the slightest. It's just that in this equation, as things have evolved, I'm not sure that I bring something unique to the shifts that I do, other than, trying to reach people around their chronic illness, which is, a little bit of an anathema to what we were taught and indoctrinated on during our training. And I will say this, I'm not sure if anyone knows this, Ann might, but one of the reasons that I stepped down from ACEP, resigned from the EMF board, and didn't stay involved with them is when we got into a discussion at one of the EMF boards about existential threats to the specialty. And someone said the biggest threat to our specialty is declining ER visits. And, I about fell off my chair, because I think we all recognize that high numbers of ER visits are representative of a failure of a healthcare system. They're not something to be championed or celebrated. And, if we go from 130 million to 90 million ER visits, the solution isn't how do we drive more people into the ER, but do we need all these ER physicians, doing this work? We've really created a healthcare system and entrained our population to rely on the ER, again, stuff you guys all know, to rely on the ER for things that in a more evolved and mature healthcare system would occur elsewhere. They wouldn't be in the emergency department. And so, that thinking, that mindset led me to, not want to be part of that organization and not really want to, at least put all my emphasis, in the ER basket. And that's not to say, again, that I'm not interested in emergency medicine. It's really more now, how do we think of the unique skill set that we have and our ability to take problems and, rapidly integrate and assimilate information so we can come up with solutions, and use that same type of thinking for things much broader than, do I give steroids to this asthmatic? Again, not trying to be a pejorative statement on this, but just kind of walking you guys through my evolution and thinking. So with that, I'm going to give you guys a little bit of an overview of what we've been doing in the last 2 years or so. As Ann mentioned, I am Chief Innovation Officer for Wayne Health, which is Wayne State's University physician group. It used to actually be called Wayne State UPG. Emergency medicine isn't even part of Wayne State's physician group. It's a completely separate subsidiary entity, Medical Center Emergency Services, which did not join the practice group because they were concerned about losing revenue and all of this type of stuff, and have been adamant about not joining the practice group. However, I reached out to them as things were evolving in my career to see if they had an interest in population health, because the one thing that was the biggest impediment to my ability to reach our population and improve care for the population is the back end. It's not the front end. We do a great job in the ER. We let everyone in the doors, as you guys know. We take the vital signs. We do what we're going to do. We do, oftentimes too much testing, but enough testing that we can risk stratify patients effectively. But how do we link them to care at the next level? I think it's something we all battle with. I know in our system in Detroit, particularly at the Detroit Medical Center, it's something that's very fragmented and didn't work well. And so when we're trying to do linkage to care activities for chronic hypertensives from the ER, and I can't assure them of a follow-up appointment, it gets very problematic. And so I jumped at the opportunity to actually re-engineer the physician group side of it and the family medicine and primary care provider side of things through this role as Chief Innovation Officer. And as I'll walk you guys through where we've been going, I think it'll make a lot of sense. In addition to this, I'm also Assistant Vice President for Translational Science and Clinical Research Innovation at Wayne State, which means I essentially oversee a large portfolio of research that effectively mirrors a CTSA-like infrastructure. We don't have a CTSA at Wayne, but we will be going in the next cycle, probably in the spring or in the fall, for the CTSA with me as a PI, which kind of gives you a sense of just how far the wings have spread at this university. Emergency medicine at Wayne State has long been a leader in terms of research and academic productivity and many, many other things. As you can see, Ann's vice chair for education for the School of Medicine, vice dean for education. Didn't mean to demote you. You are vice chair as well, but that's the second line for you now. Wayne State has long valued what emergency medicine does. And I think just the footprint we have across the landscape at the university is representative of that. And that comes from a long history of leadership with people like Brooks Bach and now Brian O'Neill, who have championed sort of that leadership role at Wayne State. So with that, I'll start in on this presentation. I also want to just say that, some of the other stuff that I've been doing over the last few years has not only expanded beyond emergency medicine, but has played an important role with collaboration and partnerships with other specialties. So I've done a lot of work in the cardiovascular space, as I mentioned. I was the inaugural chair and then was chair for 6 years of the Accreditation Oversight Committee for the American College of Cardiology. I had been the president of the Society of Chest Pain Centers, which became the Society of Cardiovascular Patient Care years ago. I engineered with leadership a merger between that organization and the ACC, and had basically been put in a very prominent leadership position within the ACC, overseeing accreditation. And now I've since worn out my welcome, I suppose. No, I have termed off of that. And so after 6 years of leading that, I now have roles over the National Cardiovascular Data Registry, NCDR. And through that, I was able to be in position to be the vice chair of the recently published AHA-ACC chest pain guidelines, which SAEM did sign on as a co-sponsor of, an endorser of. And I think it's very representative of how far we've come as a specialty, that not only was I vice chair, but more than 25% of the writing committee was emergency medicine physicians, which I was essentially able to handpick and bring on there. So if you haven't seen the chest pain guidelines, I think they're a shining example of what happens when emergency medicine not only gets a foot in the door, but is the one, leading the charge in the door. The guidelines really are very, very emergency medicine friendly and written from a perspective that allows us to not practice with fear, but practice, with evidence. And so I'm very proud of that effort. So with that, like I said, I'm going to kind of walk you through what we've been doing around mobile health. And I think as you hear the presentation and see it, it'll make a lot of sense as to why my career has taken this trajectory that it has. Before I get started, are there any questions or anything that people have? No, if not, I'm going to share screen 2 and see if this actually works. Every time I do this, it kind of screws up. So let's see if it works. Okay, hopefully you could see the slides and not the slide sorter there. Okay, good. Thanks, Dimitri. So I termed this the Wayne Health Mobile Unit because I've given this presentation various times, but essentially when the COVID pandemic hit, I was already on the point where I wasn't working so much in the emergency department. And we, as everybody else was, we were seeing a lot of healthcare providers who were exposed. At one point, half of the city of Detroit's police department was on quarantine for exposures, and there was no facile mechanism to get testing done for the population. So I leveraged my role at Wayne Health to create drive-through testing. We created the first drive-through testing in the city of Detroit at 2 locations, one in Detroit and one in Dearborn. And it was geared specifically for healthcare workers and first responders. And within 3 weeks, we had tested almost 3,000 people. Many of my colleagues, many of our friends coming through here, but many firefighters and again, police officers. And because of that, we had built this infrastructure basically to provide testing in the community, something that would avoid unnecessary visits to the emergency department and at the same time allow people who needed to get back to work and people who needed to be home and isolated. But what we started to realize in Detroit, as other locations have, is that communities of color, especially the socially vulnerable in those communities, were especially hard hit. And we started to pivot towards a concept of taking mobile units or taking care into the community and recognizing the need for data to help us figure out where to deploy units. We had been building up a vision around this for the last couple of years, something that I'll show you in a second called Phoenix, which is the Population Health Outcomes and Information Exchange. The idea behind this started with my interest in blood pressure and trying to understand the pressure load on a community. So in the HIV world, for anybody who does infectious disease work, there's a concept called community viral load. And that's a way to understand what the average viral load in the community is to get a sense of how well HIV is being managed. And Ryan White funding allows that to occur very easily because it supports all of that type of infrastructure. My mindset was geared towards creating a concept of community pressure load. Could we understand how blood pressure is impacting communities so that we could target outreach to areas of the community that are harder hit than others? And could we target the outreach that we're doing, not just towards, hey, you have high blood pressure, good luck figuring this out, but real linkage to care and also understanding the social factors that go into this so that we could come up with comprehensive population health management approaches to do targeted outreach into communities. And so I had received a large amount of funding from the Michigan Health Endowment Fund to support the build out of this Phoenix project, which again, I'll show some slides on in a second. But the idea of how we were ever going to leverage this for mobile outreach or to get out into the communities was not quite clear to me yet. I knew we wanted the data and the data infrastructure, but we needed the mechanism, the vehicle, so to say, pun fully intended, to get this done. So after we started doing our COVID hit as we were building all this stuff up, as we started doing our COVID testing, and we started to realize we needed to get beyond the healthcare worker and first responder population. We need to get out into the neighborhoods where people were particularly hard hit and better understand what their risk factors were, provide testing, but also provide full-on wraparound services in case somebody was identified with COVID so that we could do more than just test them and say, hey, you don't have a safe place to go or, you're homeless, good luck with all of that. And so we built up all this infrastructure, and to date, we've now had over 62,000 encounters in the last 14 months or so. As you can see, this is the mix of COVID tests and vaccines that we've done. This is our dashboard that we're in the midst of modifying. You can see that we include patients seen by month and changes in COVID positive tests and different rates and all sorts of information. But again, this all started with a concept of Phoenix, the Population Health Outcomes and Information Exchange, which was a way to take multiple different data sources, amalgamate them at a geospatial and temporal level so that we could understand what mix of social determinants and health risk factors and health outcomes are existing in certain communities, target programmatic evaluation and intervention to tailor outreach into those communities. And so we built up this infrastructure, started working off of ER data to start with between Henry Ford Health System and Detroit Medical Center. Those are the two largest health systems that treat, the city of Detroit. There's also St. John's Ascension, but which is also a very large health system, but a little bit further on the outskirts of the city itself. And started pulling in ER data and quickly amassed well over 1.5 million ER encounters, added geocodes to every one of those encounters, and then took blood pressures and started mapping out blood pressures by census tract so that we can understand the quote unquote pressure load in the community. And the reason to do that is that at the population level, if you lower blood pressure by 1 or 2 millimeters of mercury, so not myself or Ann going from 130 to 128, but an entire community going from 135 to 133, you can dramatically reduce the incidence of cardiovascular disease and strokes. And so we wanted to start to get this idea of these numbers so that we could tailor this outreach. And that's where this Phoenix program came in. And we started pulling in EHR data, like I said, and then started getting data use agreements with EMS, with our medical examiner, started pulling in multiple different social determinant information, getting agreements with the SNAP benefits program at the state level, getting agreements around dental benefits, having any and every piece of information we could get our hands on, plugged into this system so that we can combine them for action, really looking at where we target programs, like I said, hotspots and outreach, and then track and monitor trends and changes over time passively, because we get continuous data feeds on all of this. So again, this is just an example to me to tell you of sort of something outside of emergency medicine that was born from emergency medicine, but has now emerged as a major pillar of the work we're doing at the university from a population level. And in creating this vision and building out this vision, it required a lot of informatics infrastructure development. It required us to learn, all of the different cloud-based platforms and decide what the right platform it is, work with Google Cloud engineers. We ultimately settled on Google Cloud Platform, but it required a lot of understanding that is just well beyond, what we typically do in emergency medicine and emergency medicine research. Again, thinking population level. So that's the backdrop of where that second slide came in of all the work that we've been doing. And because we had this setup in place when COVID hit, we were able to spin up maps like this on March 29th, 2020. So 9 days after we started doing our outreach efforts. First case in Michigan was March 10th. By March 20th, we were doing our outreach efforts. By March 29th, we were creating nuanced maps like this, which showed around Sinai Grace Hospital, where Anne does a lot of her clinical work. At Sinai Grace Hospital was the largest hotspot at the time in the city of Detroit for COVID. And that was the one that was getting on CNN with bodies piled up in rooms. And, the first area where we needed to bring an outside morgue in and the like. We started putting on our maps the information that we knew was going to be relevant to understand why this area of the community was so hard hit. We were already recognizing age greater than 65 was important. We were already recognizing social vulnerability was important and incorporating this stuff into maps so we could think about how we tailor and target outreach. Detroit being Detroit, the Ford Motor Company being an automotive manufacturer in Detroit, we got linked up with the Ford Motor Company, and within a couple of weeks, Ford had donated to us 4 transit vans for preliminary work to do mobile outreach into communities. Working with our partner organization, Access, an Arab health organization in Dearborn that happens to be led by my wife, worked out quite well. We were able to start doing this mobile outreach program with sort of an alpha version, if you will, of our vehicle setup, where we were taking standard standard transit vans, putting equipment in the back of them, and then setting up with tents, these mobile testing sites. As you could see, these days we were using plexiglass dividers and, didn't really know some of the safety and protection concepts. But we were starting to do this, and we were starting to get a lot of receptivity to this model. We had a lot of police departments still asking us to come to their sites and test their officers, but we were starting to get a lot more interest from the community in doing community outreach and community events. But we quickly realized that if we're going to be out in the community, we need to be doing more than just COVID testing. We started thinking about our concept as a model of portable population health. We started doing antibody blood draws early on, not sure what the relevance was going to be, but the community wanted them. And while we were doing nasal swabs and antibody blood draws, we said, hey, we could start measuring lipids and hemoglobin A1Cs and looking at, kidney function. We could start doing blood pressure measurement and taking hypertension screening into the field. So not just slapping on a cuff on somebody and, doing auscultative methods. We were using or started using Omron 907 XL, measurement techniques, which are the state-of-the-art measurements of multiple measurements where you take the average in unattended manners and, and that's the way you look at blood pressures. Started doing HIV screening, which we do in the ERs now. Our emergency department HIV screening program is the largest HIV testing program in the entire state of Michigan. We test more than 10,000 people a year for HIV. Started doing vaccinations, pediatric vaccinations and flu vaccinations, and started prepping a vision for what the next version of vehicles would look like, anticipating COVID vaccines to put in medical grade refrigeration into the vehicles. And so, as you can imagine, this isn't cheap. And while we started out the whole process initially of volunteerism for the first couple of weeks when we were testing, doctors and nurses and police officers, volunteerism only goes so far. And so we started realizing the need for funding, and we were able to have the philanthropic community rally around us. And within a couple of months, we were able to pull in close to $2.5 million in funding from various sources. Among those, the Community Organized Relief Effort, CORE, which is Sean Penn's foundation, came in with multiple donations that totaled more than $560,000. You name the foundation in Southeast Michigan or beyond, and they were giving us money. Around this time as well, the state of Michigan was really becoming concerned around the sort of disparate outcomes that are noted in Detroit and in the brown and Black community. And they created a racial disparities task force to look at outcomes in COVID populations. I was appointed to that task force, at least part of the task force, and they adopted our model of mobile health outreach as a pillar of the task force and funded our program in the first year, after we started doing this, for about $4.6 million. So very quickly, like I said, we were able to bring in all of this money, which we were able to work with Ford to build out new vehicles, upfitted vehicles. We also, at the same time, because we were getting some traction around all of this, caught the eye of Steven Soderbergh, movie director, who was in town shooting a movie called No Sudden Move. If you haven't seen it, it's on HBO Max. It's wonderful. It's about the 50s in Detroit. It's got a really star-studded cast, but they basically hired us to come on site and do all of their COVID testing because we had a mobile program. And Steven liked our work so much, he personally himself donated $200,000 to buy 2 more vehicles. So with all of this funding, we were able to spin up a new program. And that program incorporated, as you could see here, this isn't it here, I'll show you the new vehicles in a second, but we incorporated additional things like patient health navigators in the field, because if someone doesn't have insurance, we want to help them get insurance so that they can, again, stay healthy during COVID. We started doing things like social determinant assessments in the field and having our navigators and other folks address these needs. We do fresh food and produce distribution at some of the events, but we have a social determinant intake process that allows us to deliver more comprehensive services on site. And so we went from a model of COVID testing to a model of portable population health. And as I said, to date, we've had over 62,000 encounters, and this is what our team is now. We went from having no vehicles and no people to I have a team full-time of over 100 people, and I now have 7 vehicles with another 2 on the way. And these are the vehicles that we designed with beautiful wraps and these awnings so that we can continue to do drive-through testing, but we also have the mobility to go deep into neighborhoods and do point of care screenings and linkage to care and whatever we want. And you might not be able to see it clearly here, but not only do we do, all of our COVID stuff with the medical grade refrigeration in the vehicles, we draw blood, we do centrifuging, we spin blood on site, we bank blood from our site. So we've incorporated research on top of what we're doing in our mobile health outreach program and have really rethought care. And as I'll walk through this a little bit more, you'll see how this continues to evolve. We caught the eye of the Rockefeller Foundation and the Margolis Center at Duke for our work and started working with them on publishing, our strategies, and recently got our mobile health unit paper accepted at PLOS One, which will be coming out shortly. But, having an emphasis, a locality spotlight on the work we're doing in Detroit around this sort of collaborative effort to build out outreach. And none of this would have been possible if I didn't branch out beyond emergency medicine into Wayne Health, because the emergency medicine group and the team were so focused, as they had to be, on the ER. Right? They couldn't think beyond the emergency department, but because I was in a position to do this, I was able to have the academic freedom behind this. And so we now have something you can see right here where you can go to our Wayne Health website. We have all of our events listed. You can click on an event and you can see all the different things we'll be doing at the event and what other services we'll be providing. And now it's morphed beyond that to the point where we're working with the local business community, especially the manufacturing community, to bring healthcare to local businesses. And we're looking at ways to get direct contracting with our program for outreach for prevention services. So while we go on site to local manufacturers and do COVID testing and whatnot and vaccinations, we're also screening for hypertension, screening for all sorts of other comorbidities, and then building out linkages to care, for folks to come back to our clinics. But as you'll see, we've even adapted that model and innovated a little bit further. Kind of cool stuff. This is an example of one of our partners that we work with, Detroit Chassis, which is a Black-owned business in the city of Detroit that operates out of the original Dodge Brother chassis plant built in the 1900s. It had been dormant for years. They bought it about 20 years ago. They employ almost 400, mainly Detroit, largely Black, community members. And so we work with them to go out to their site, and this is our setup on their location. And we've been going out there recurrent times, but we've now, in over 3 events, we've now reached 1/3 of their employees. And in an hour over a lunch break, we can see 50 people and get blood pressure screened, do vaccinations, do, all sorts of testing. And so, we're rethinking what this vision looks like of what care is, and really thinking about how we bring care to people, making it as easy as possible for them to receive the services they want. And we're ultimately building out a model towards capitated contracts that potentially will bypass insurers, having businesses contract directly with us as Wayne Health for prevention services using capitated rates that reflect age and sex-specific prevention, guidance, and working towards a model that we can deliver hypertension care, diabetes care, whatever care we want, colorectal cancer screening, mammograms, at work, all out of this vision. And while we have been working with businesses, we also have grown our data portfolio and our understanding so that we're moving beyond just working with community groups and businesses. We have over 800 events that we've done at this point, over 250 different community partners. But some of the cool stuff we're doing now are taking things like SafeGraph data, which I'm not sure if you guys know this, but that's cell phone metadata, basically showing where people are in the community. And we take cell phone metadata, and we can identify where in a given neighborhood the biggest congregation of people are, so that we can have healthcare delivered right in people's faces, right? We can make healthcare part of your activities of daily living. This is an example of our vehicle being placed at a surface parking lot on an area called Grand River and Fenkell in Detroit, a high volume area, and people can come by and get information, get tested, they can get whatever the heck they want. With this, we also do door-to-door campaigns and go from house to house, sometimes doing vaccinations in homes, measuring blood pressures in people's living rooms, and drawing blood, in their house, and doing linkage to care. And so this evolution, again, has taken time, but it's been, a real amazing journey. We've done further things that, because of our success, we've been able to pull together all of our groups in the area. Not only have we been leading the charge around mobile health, but other groups have brought together resources and gotten mobile units. And we have aligned all of these units in something we call the Michigan Mobile Health Corps, which we had Kellogg Foundation funding for this, and basically took all the units that exist in the area, and instead of them operating independently and potentially overlapping in where they're deployed, we actually coordinate deployment of the units based on data. And in this case, we use data that's specific to vaccination rates at the census tract level that we get from the state. Big battle to get the state to give us that information, but now the state gives us to us, and we can target communities with low vaccination rates and try to drive up the vaccination rates. And here's just an example, looking from August 24th when we started this project to October 21. We're still waiting for some updated data from the state, but we can take information on COVID prevalence, look at where we've done our vaccination sites in the area, look at the change rates in those communities, and then do a cross matrix on where we've deployed vehicles and the increase in vaccination rates. And when you see this, you see certain areas in the community where our vehicle exercises and outreach have led to at least a 10% increase in vaccination rates in those neighborhoods. And so this is the type of stuff that really is, has grown for me to be the most rewarding stuff that I'm doing these days. And then it ties into the grant funding, which, was alluded to a minute ago. Because of this work, we were able to partner with 4 other institutions for an American Heart Association $20 million award to fund a health equity research network. NYU and Benga Ogedegbe, some of you may know his wife Chinwe from Hackensack, New Jersey, but she's an ER doc. But Benga and I are good friends, and we designed basically a network around prevention of hypertension, which is what the AHA was calling for in this health equity research network proposal. And we have 4 other institutions doing projects. Ours is by far the coolest. It's called LEAP Hypertension, and it's basically taking our mobile outreach, using geospatial analysis for deployment of vehicles, and putting community health workers on the vehicles and having them become the primary care providers for patients. Having CHWs who are properly trained, have backup from nurses, obviously on site, and physicians on the very back end, but putting them in the field so that they can work with folks to identify what are their individual social determinants and how do we address them? How do we come up with collective plans so that we can empower folks expand access, improve linkages, and then look at, effectiveness and maintenance of our efforts. And so this grant, 20 million, our take on that is 2.6 million, which funds LEAP hypertension, which is one project, but that directly led to this next project, which Ann mentioned, our P50 funding. Very close to after we submitted the AHA grant, the NIH came out, NIMHD, the National Institute of Minority Health and Health Disparities, came out with a call for transformative projects to decrease chronic diseases, focused specifically on underserved communities. I was very reluctant to get involved because, we had a lot going on. And then all of a sudden I was the PI of this major effort. And so we submitted this and got a great score, a 34, which doesn't seem like a great score if you've submitted an R01, but actually for these types of RFAs, it was a very good score, great score. And we got funded along with 10 other institutions in the country. Again, the only ER facing, or at least ER leadership on this, but this isn't very much emergency medicine, as you guys can see. But the grant basically funds 3 projects, and these 3 projects are similar in vein, using mobile health units, but targeting stage 1 hypertension. The LEAP hypertension project targets elevated blood pressure. So just before you get diagnosed with hypertension, if your blood pressure is 120 to 129 systolic or 70 to 79 diastolic, you qualify as elevated blood pressure, but not hypertension. So we develop projects to look at early intervention for stage 1 hypertension, early intervention for stage A heart failure, which is basically more complicated hypertension. And then really cool, through a colleague that I was able to recruit from University of Michigan, Rob Brook, to come down to Wayne State. He had been a tenured professor, had an endowment, had been living large as a director of all of the hypertension research at U of M, left U of M to come down and work with me because of this vision of what we were creating, because he was tired of doing projects that looked at, aldosterone receptor polymorphisms, but wasn't helping the population, and wanted to come down here and make the biggest impact. And he had a colleague in Cleveland at Case Western, Sanjay Rajagopalan, who does free coronary artery calcium screening in the community. He's done more than 60,000 people with free CAC scores, but had only 5% Blacks and very few low-income populations. And so we got him involved in a partnership with the Cuyahoga Metropolitan Housing Authority and built in 3 really cool projects that all target early intervention, with an idea that we want to expand and improve lifespan health equity and lifespan equality. The idea being that people in Detroit and other similar urban underserved minority communities have decreased life expectancy, maybe up to 15 years in certain neighborhoods. What does it take to make everybody live the same number of years? What does it take to expand the equality of lifespan for everybody? And that's a primary emphasis of this project. And then, as I mentioned, we're doing other things. We work with our needle exchange program in the state of Michigan. We do lead testing. Our program is the only approved mobile lead testing in the state of Michigan. And Benton Harbor, which is on Lake Michigan and about 2.5 to 3 hours away from where we live, we deployed vehicles to Benton Harbor to do lead testing after it was recently discovered that there's a high concentration of lead pipes, and they were concerned about that. So our group was over in Benton Harbor doing that. And now we're working with our mental health community here. Detroit Wayne Integrated Health Network is the overseer of Medicaid funds in the state of Michigan for people with substance use disorder and severe mental illness. We started partnering with them in an effort to do mobile outreach, not targeting communities just in general, but actually taking our Phoenix data on ER utilization patterns for mental health and knowing where we want to deploy vehicles in the community. And what's really cool is not only have we been looking at where high utilization is, a lot of what we're focused on now is underutilization. So they administer all the Medicaid funds, and they'll know who's not using services. And the 2 groups that are going to decompensate are probably those who use the ER a lot for decompensation and those who are not using any services at all. And so we deploy vehicles now under a contract with them to different areas of the community and work to reduce ER recidivism. we just got another $900,000 in funding from Bank of America to get 2 more vehicles, which will bring us to 9, where we're going to be using these vehicles primarily in this program and incorporate in-vehicle telehealth capability, because we have a huge digital divide in Detroit where people can't use telehealth a lot of times because they don't have the Wi-Fi capability or the devices. And so we're going to put vehicles out there that people can work with us and come on site for this type of thing. And so, that's the model that we've been operating under. We've been, like I said, incredibly successful, both with funded projects through grants and through other work, and also building up a fee-for-service line and a model towards sustainability around alternate contracts and alternate payment models. And so that's kind of what I wanted to talk to you guys about. Just give you guys a little bit of an inkling and an insight as to what I've been up to, but also paint a picture of how our training as emergency physicians and our sort of preparedness and fortune favors the prepared mindset has allowed me to get where I'm at right now, and has allowed me to create these expanded opportunities, not just for Wayne Health, but for emergency medicine as well. One of the cool things about the P50 is that it's got 6 $40,000 a year funded pilot projects for 5 years. So I have the ability now to fund 30 $40,000 projects over the next 5 years, several of which obviously will go to my emergency medicine colleagues as they apply. So not saying I'm biased, by the way. So there's not to imply that, but it's been a really nice journey to be able to get to this point. One, I had no idea I was going to be going on when COVID hit. I knew I wanted to get involved in the population health space, and then everything just kind of clicked, and it's really led to a very nice setup and situation, and most importantly, something that's providing true care and meeting needs of our population. So I'll stop there. Obviously, you guys can tell I've said this a lot, and I tend to ramble when I go through this, but I appreciate the opportunity just to share what we've been doing in this vision with you guys.
Thanks, Dr. Levy. I presume people are going to have some questions for Dr. Levy.
Yeah, I'll start. Phil, congratulations on all you've accomplished. It's really very impressive. I don't know how you sleep or when you sleep or if you sleep. So congratulations on that. What struck me as you talked for the last hour, you're describing your professional identity reforming over and over again. Like, at one point you were an emergency physician and an emergency medicine researcher, and perhaps you might be a population health researcher. I'm curious what you label yourself as right now, right? So you've gone through a lot of Phil Levy's along the way. Like what do you think you are now, especially with a title of innovation? What are you? The
Chief Innovation Officer.
Chief Innovation Officer, but doing a lot of research. Like those two things don't always line up at a lot of institutions. So what would you say your professional identity is now?
It's a great question, Mike, and it's good to see you. And hopefully this triggers some of the stuff when I was out at Stanford giving the talk with the maps and everything, because that was the beginnings of this, right? And and this has evolved a lot since that point in time. In some levels, I refer to myself as a translational epidemiologist, which is kind of funny, but it's this idea that we have a lot of data, and we could churn out paper after paper if we wanted that could continually say it sucks to be poor and Black in Detroit. And we don't want that anymore. We want to do action. And it's really, I guess the way I look at it right now, I think of myself as sort of this mix of a research leader at the university. I'm in the midst of negotiating my next package after getting an $18 million grant. Is always a great time to do that. But trying to figure out what that looks like. I have a hat I wear as a lead research administrator for the university. And that largely has come from 20 years of doing this work and knowing everybody, right? One of the biggest ways you're successful as an administrator is by knowing who to call when stuff's not getting done, and having that person actually like you enough to want to help you and not be like, oh, that guy again. And so as I figure out that side, and as we move forward with the CTSA application, that research administrative leadership is a big role. But then the other one that I really define myself as a population health expert. I don't know if expert's the right word to put behind that, but I talk a lot about population health as being the passion that drives me. And, it's not that I don't value what our specialty does. It's just in a system and a setup like ours, where the emergency department really reflects all the problems with everything else. again, it's not that people don't need to be in the ER, because a lot of them do, but a lot of them don't. And if we only had the infrastructure in place to help them, then we could. And to me, that's the population health side of this. And it's moving, I guess, beyond the one-on-one encounter at the bedside to the how can I help the most people in the community I live? And that's the mindset and the flip that kind of has occurred with me. I hope that answers the question.
Any other questions?
Well, I have a question for you. A few years ago, you were out here at Rutgers NJMS in Newark when Lewis had you over as well. So you've kind of been out here. You went to NYU, you know Newark as well. One of the questions is, ours is a community very similar to where you are in Detroit. One of the challenges we've faced is, despite being at a public hospital, not having an administration that's really bought into the idea of population health, which seems kind of counterintuitive, but that's the reality we live in. Any suggestions, ideas for how to lobby the institution more? Because it's great when you have leadership that supports what you want to do, but it kind of sucks when you have leadership that's not seeing it, institutional leadership, that is. And I don't know if you have ideas in terms of how to go about that, including from a grant standpoint, as well as lobbying them.
Yeah, it's a real tough one right there, because, you know, the from the ER pulpit, I was unable to get people to hear. I mean, they could hear a little bit once we showed the vision, or once I started going around and showing the vision of the data, you know, and how impactful it can be. You know, they started listening, but they weren't ready to invest in this. And then I got the opportunity to present at the state of Michigan has something called the Mackinac Policy Conference, which is where every political person in the state of Michigan goes. They go up to Mackinac Island for a couple of days, and then they hear all these talks, and they get very drunk, and everybody, you know, BS's each other. I had the opportunity to go up there and present this on behalf of Wayne State, which caught the eye of the Michigan Health Endowment Fund, which is the administrator of all of the tobacco settlement dollars in the state of Michigan. So they came in and said, we want you to send us a $500,000 proposal. And I did, and they funded it. And then the city, the university, seeing that and recognizing there was traction behind it, matched it with another $500,000, which gave me the kickstart to build all of this infrastructure out. Along the way, it really was sort of a matter of getting people behind the success that was occurring. And I know that's, it's tough to say it that way. But beyond that investment, you know, I didn't really have Wayne State clamoring to sort of jump into the pool with population health. A lot of universities talk about it, but they don't really know how to do it. And it was this opportunity to bring in the practice group. It was this opportunity to have a forward-thinking leader in Wayne Health, a guy named Chuck Shanley, who's a vascular surgeon, who's the president and CEO of that group, who, you know, said, okay, we'll bring you on in this role to help drive our population health vision. Neither one of us knew what it was going to be. And the only way it really, really started to get successful is when we just started to do it. And, you know, we got fortunate by having Ford come to the table and support us, and all these philanthropic organizations come. But I hate to say it, Harsh, it's very hard to, you know, get funding without funding, and funding begets funding. And so once we started to get a little bit of success and people started to see what was going on, it really catapulted things. But I think it was that ability, that opportunity to present in front of, you know, that particular audience that really stimulated the university to say, hey, we're onto something. And then getting in front of all of the folks at the state level. Once we started, moving forward with our vision and being incorporated into this was huge. You know, I now get phone calls from the lieutenant governor, you know, asking for my help with stuff. And, that type of thing really caught the eye of the university. Now we have something. Now we have, a way to gravitate or to have people looking at Wayne State, and in particular, you know, the work I'm doing, which then moved it forward. And then, you know, getting AHA funding and NIH funding were further validations of all of this. So, you know, it's tough to get that first, that kickstart, right? It's tough to get that first thing to go forward. But in all of this, the pandemic, you know, really created a very unfortunate but fortunate circumstance in that it sucks for everybody who, you got sick and died, all of that. But it's created an opportunity for people to think outside the box a little bit and a better receptivity to that mindset. But, getting a university behind this is tough. But I will say, I'd be delighted to talk with whomever at Newark, be delighted to share our whole model and any grant you want, anything like that. Be delighted to work with you on supplements to what we're doing to look to how to expand the model, because I really do think that there's a lot of dollars that are coming at the federal level from CARES Act and beyond that are going to continue to go towards this. And I think those dollars are there for the grabbing if you have the right setup at your university.
Those $40,000 grants that you're going to have essentially 30 of over 5 years, are they just for Wayne State, or could anyone on this call apply for something like that?
It's their Wayne State, Henry Ford Health System, and Case Western generally, because we're trying to create sort of mentored cohorts each year of local investigators. But that said, like I just alluded to, Anne, there's a lot of opportunity to take this model and expand it to other things. And Harsh, while I didn't say it, one of the things I learned more than anything that has been huge is NIH funding is great on your CV, but it's a pain in the ass, right? We all know this. And the foundations and the philanthropic groups are a much lower bar to get the funding, but they write big checks, right? They, Bank of America came to me the other day and said, all right, we want you to submit a proposal for $900,000. I'm like, great, we're happy to do it, right? And, with a 2-page proposal that someone in the development office wrote and I revised, we got more money. And so I think looking at those alternative streams of funding, particularly now with innovative ideas that tie into, the model of an approach to better community care around COVID is a great inlet for that. And, alternative funding too, like we don't typically think of HRSA funding or CDC funding in emergency medicine. I mean, I know we do and we don't, but HRSA has tremendous dollars out there for things like COVID, vaccine hesitancy and whatever that can be adapted towards a bigger vision. So, just to say that's probably one of the other big lessons, I learned through this.
Any other last minute questions? Oh, okay. Well, thank you, Dr. Levy, very, very, very much for doing this. It was very inspirational.
Dr. Messman, I'm glad to do anything you ever asked me to. And likewise, I'm delighted if you guys want me to share slides, if you want me to, talk to your groups, I'm happy to do that. And I'm happy to share any grant that I've ever written and happy to read your grants if you would like.
Great. Thanks so much. And thanks everyone for joining.
Thanks, guys. Take care.
Thank you.
Bye.
Bye-bye.
Bye. Thank you.
Bye.